Please start.
Okay. So 57-year-old gentleman with acute onset of numbness of right side of the body since today morning. Uh, so since it's of numbness of right side, it can be of uh, coming to a differential diagnosis like stroke, uh, transient ischemic attack, and maybe peripheral neuropathy. Um, then uh, sometimes in case of migraine and all, there can also be uh, presence of numbness.
Fine, fine. When in this, which system is affected here? Nervous system. Okay, nervous system involvement. So basic principle of nervous system involvement is always give the anatomical site of involvement. Then we will go to etiology, pathology, risk factors. So step 1 is the anatomical localization. When somebody comes with acute numbness of the right side of the body, either acute or chronic, numbness of the right side of the body, what are the possibilities that comes to your mind anatomically?
Lacunar stroke.
And I'm not talking about pathology. Lacunar stroke is a pathology. Lacume is a pathological term.
Spinal cord.
So you think it is spinal cord. Why do you think so? Why do you think so?
Sensory involvement with lesion. It can be involving spinothalamic pathway because lesions is leading to numbness.
Numbness. So one possibility you're talking about is spinothalamic pathway at the spinal cord. But remember, right side of the body means right side of the face also.
Yes, sir.
So what do you think? Okay. Second anatomical site, where do you think? Other than spinal cord?
Thalamus.
It can be thalamus. Where else can it be?
Brainstem.
Can be brainstem. Why do you think it's brainstem? So today's class we are concentrating on sensory system examination basically and trying to localize anatomically. Then we'll go to the etiology. Okay. So history analysis. Anything else you would like to know in this patient?
We'll ask for associated symptoms
like
vomiting.
Vomiting.
Then
the aim of the history here is anatomical localization.
Anatomical localization.
So does vomiting localize anywhere? Need not be localizing value.
We'll ask for pain.
Pain. What does pain indicate to you?
Pain in androlateral pathway, it is pain involvement in case of dorsal column, only numbness, vibration sensation, etc. If it androlateral pathway is involved, there can be pain.
Okay, anything else you want to ask in this patient?
Root pain.
You want to ask root pains, very good. Can you tell one sentence about
nerve entrapment?
Can you tell one sentence about root pain?
Shooting type of pain.
Starting from near the vertebral column center part.
Along the root distribution.
Along the root distribution. So what increases it, what decreases it? When intraspinal pressure increases, it increases. When it decreases, it decreases. Cough, sneezing, laughing.
Bending.
Straining at stools.
Movement, straining and all can increase.
Very good. Anything else you would like to ask?
Uh,
In a nervous system, in the sensory system examination, there are positive symptoms and negative symptoms. Would like to comment on that?
um, in case of stroke and all, negative symptoms like numbness will be more negative. Tingling sensation, pin and needle sensations, then paresthesia.
Paresthesias, hyperesthesias, hyperpathia, allodynia, all positive. Okay, so abnormal sensory symptoms, positive and negative. Tingling, you said, pins and needles, itching, band-like sensation, lightning sensation, shooting pain, burning, often painful. They are all positive symptoms. Negative symptoms are numbness. Now, suppose you touch somebody and he appreciates as a pain or unpleasant sensation. What do you call that term? That means increased sensitivity.
Hy- hyperesthesia.
Hyperesthesia, hyperpathia, allodynia, they all come like that. And this patient has acute illness possibly points to a vascular episode. So he does not have, his complaint is numbness, negative
Yes, sir.
problem. He doesn't have a positive symptom. Okay, right. So how do you localize numbness? Where is localization numbness? We are going for anatomical localization numbness.
So we'll ask
Where does this
face.
sensation start from?
Um,
Sensation start from where? From receptors.
Receptors.
And where does it go?
Uh,
Where does it end? Sensations end where?
Spinal cord. Dorsal column.
Spinal cord. And after that?
Cortex.
It goes up to cortex. So localization can be anywhere in this pathway. And we are trying to localize this lesion today. This class is meant to localize numbness. Okay, that's our job. So
Yes, sir.
parietal cortex to peripheral sensory receptor. Anywhere. So how do you localize in a peripheral nerve? How do you localize in a peripheral nerve? When the numbness is localized to the sensory area supplied by that nerve, you think it is a peripheral nerve. For example, you have got myalgia paresthetica, which is confined to the area supplied by the lateral anterior cutaneous nerve of the thigh. So that's how you go. Peripheral nerve, neuropathy, and if it's peripheral neuropathy, bilateral glove and stacking pattern, mononeuropathy, symptoms in that territory of that nerve. That's how we localize it. After nerve, what happens? Go up after nerve. Yeah, dorsal root. How do you localize that?
Dorsal root ganglion.
How do you localize?
Root pain.
Root pain is good, and you have dermatomal involvement of the sensory complaint. It is not a nerve distribution, but a root distribution. So dermatome pertain to dorsal root. After that, where does it go? It is in the
Spinal cord.
spinal cord. How do you localize there? So if you got a spinal cord,
Segment.
have a level of sensory loss.
Level.
Okay, you may get band of paresthesia above that level. And if it's transection, whatever is passing through the spinal cord, motor, sensory, autonomic, everything will be lost. And hemisection, you know the findings of Brown-Séquard syndrome. And in the spinal cord, also you may have selective tract involvement like dissociation or suspended anesthesia. So how do you go to the brainstem? How do you localize in the brainstem?
Cranial nerve involvement.
No, we are going only by sensory system today. We are not taking any other anatomical structures. You are right. There are cranial nerves. Crossing pattern. So ipsilateral numbness on one side of the face and contralateral on the opposite. Why is it so?
Opposite side.
What is the reason behind it? Anatomy.
Because in case of
tell me the sensory supply of the face.
Sensory supply of the face means trigeminal nerve.
Trigeminal nerve. So it has got separate pathway.
Three divisions.
It has got a separate pathway. That's called as trigeminothalamic pathway. Previously called quindothalamic. Now it's called trigeminothalamic. And that pathway is different from the pathway of the spinothalamic tract. They are going different ways. So they have to join together to get the, and coming to thalamus, what happens?
The VPL nucleus.
So thalamus,
in case of sensory deficit, VPL nucleus of the thalamus involved. Ventroposterolateral nucleus.
The sensory loss will be the opposite side with unpleasant, poorly localized pain of burning quality, hyperpathia, hyperesthesia, and coming to the internal capsule, how do you localize?
In case of posterior limb of internal capsule, hemiplegia.
Yes, that's right. That's right. Other tracts, pyramidal system, visual fibers may be affected. Coming to the cortex, how do you localize?
Cortical signs.
What are they?
Joint sense aphasia, higher mental functions.
Which all sensations? Which all sensations?
Tactile localization.
That's right. Cortical sensations. 5 are there. Localization, discrimination, 2-point discrimination, sensory attraction, stereognosis, and graphesthesia. They may be helpful, but if cortex is affected, usually you get cortical sensory loss. Okay, not the primary sensations. So, whenever the primary sensations are lost, you don't check for the cortical sensation. Other lobar signs will be present. Okay, in our patient, he gives past history of diabetes for 20 years. He's on OHA, metformin, glimepiride. He's on hypertension on Nicardia tablet, losartan, and no history of TIA or ischemic heart disease. So what do you think about history so far? What do you think about history?
Stroke, CVA. He is high risk because his past history represents high risk for stroke, that is diabetes. Then
systemic hypertension.
Hypertension, and so also he's on the medication.
On examination, these are the findings.
Higher mental functions are normal. Cranial nerve normal. The motor system is also normal. All sensory modalities impaired on the right side of the body, including face.
That's right. So, what is your diagnosis now?
Lesion is in the thalamus.
You think it's a thalamic lesion. So, tell me about the sensory pathway. Let's go to the basics. It's a long case discussion. So, we are going to the simple basic clinical methods as you learned in 3rd semester. So, what are the receptors? Tell me about the receptors. Sensory receptors, what are they? What are they called? What are the names? What the
dorsal column pathway and
no, receptors are meant for different sensation: touch, temperature, pressure, deep touch, heat, cold. That's it. That's what's called as sensation. For these sensations, pain, there are different receptors. What are the receptors? Name them.
Meissner receptors, then Merkel receptors,
Good.
Pacinian corpuscles,
Excellent.
free nerve endings for pain.
Pain. Any end bulb? Cross end bulb? So you have different types of receptors. From receptors, where does it go? Your touch sensation, for example, is detected. Now where does it go? How does it go?
Through the
Trace the pathway.
fine touch sensory nerve through dorsal root of spinal cord.
Yes.
Dorsal root ganglia.
Dorsal root ganglia. First order neuron end there, is it?
Yes, sir.
Okay. Then
from there, dorsal root, it reaches the spinal cord, posterior. Dorsal column ascends without crossing, and the lateral column cross to the opposite side.
no. Tell dorsal column separately, spinal thalamic tract separately. Both are in the nerve now. Where does it go? Posterior column, where does it go?
Posterior column, it goes to dorsal nucleus of gracilis.
So dorsal column is first order neuron or second order neuron?
First order neuron.
Okay, lateral spinal thalamic tract is second order neuron or first order neuron?
The second order neuron.
Okay, that's fine. So you already said pain and temperature comes there. It goes up for a few segments, anastomose there, and then cross to the opposite side. So it is anastomosing at the level of the, first it goes to the dorsal root ganglia. From there it goes up, and then after a few segments it crosses to the opposite side. Then it ascends up the lateral spinal thalamic tract, and it passes through all structures, spinal cord,
then brainstem, while reaching the medulla,
medulla, pons, and midbrain.
Midbrain.
Then it goes up, goes to the thalamus. Yes, and posterior column, trace the pathway. Posterior column. And set nucleus gracilis and cuneatus. Then they cross the opposite side. Where does it reach? It joins the lateral spinal thalamic tract, and then at what level they join the trigeminal fibers? And it joins the trigeminal fibers at the upper level of pons. From there on, you will be getting hemianesthesia. Till that time, you are getting crossed anesthesia. Is the point clear?
Yes, sir.
So in the process, it's passing through internal capsule, thalamus. So the sensation. So we have got now 8 patients here. They are all named A to H. Tell me, A, where all can you localize? You already learned this basic now, we already told you. Now, as a student, you examine this patient and then you have found out the findings. You have drawn a picture like this and shaded. So these are the areas. Before we go to that localization, tell me how you will proceed with the examination of sensory system. Sensory system examination must start from the area where the patient is telling you is the problem. You don't start from some point and go. You start from the abnormal area of sensory loss and then go to normal area. For example, if you have got paraplegia, numbness of the lower part of the body, you start from the toes and go upwards. You don't start from the head and go downwards, because patient may feel that you are coming down from normal and he will keep on saying, I can appreciate, because he is anticipating. To avoid such errors, you always go from the abnormal area to normal area. And this is how you have found out. Once you have found out abnormal area, it is your job to touch temperature, pain separately. Why do you do like that?
Because both follows different pathway.
So there may be dissociations. So for A, picture A, what does it mean to you? Localization.
Picture
A.
mid brain stimulation.
Oh dear.
Sorry. It's a thalamic lesion.
So it is possibly thalamic lesion. It can be internal capsular lesion also. Picture B, what does it mean?
Picture B is mid brain stem lesion. With ipsilateral.
It can be medulla. It can be mid-brain. It can be the lower pons. At upper level of pons, they get joined together. Now coming to the picture C, what do you find?
It's a transverse thoracic spinal cord lesion.
Okay. And what else has happened to picture D?
Central cord lesion, like cape distribution of spinothalamic.
That's very good, excellent. And picture E?
Picture E represents generalized peripheral neuropathy.
Why do you use the term generalized? Peripheral neuropathy, okay. Now coming to picture F, you find this type of pattern. One side is paralysis, opposite side you find anesthesia, and a band of hyperesthesia around Charcot syndrome. And what is happening to picture G? Carefully look at the picture.
Affecting sensory roots.
Sensory root, excellent, very good. Can you tell which root is it?
L5.
Upper limb, how can be L5?
Sorry, sir. Upper limb, it is C5 and...
See, in the sensory system examination, you must learn basically dermatome pattern. Dermatome you must know. This thumb and the index finger is C6.
C6.
So you have to learn again. Tell me everything. C1, where is it?
C1 has no sensory.
Okay, C2, where is it?
C2, occipital region.
Axilla, what's the dermatome supplying? Axilla dermatome.
Axilla, it is T2.
T3. And little finger.
Little finger, it is C8.
Big toe.
Big toe. L4.
L5. So you have to redo the dermatome again. Once you know which is the dermatome, it's easy for you to tell which root is affected. So you have got the whole. Anyway, you have done extremely well. You told almost everything without any problem. So excellent. Okay. Now dermatomes you must know. Okay. So you know the distribution of different dermatomes. Okay. Everything is written here. So I need not explain. You know, unless you know the dermatome, you cannot proceed with sensory localization. So everything is given here, crystal clear. Unlike a common picture, every dermatome is separately given for you to memorize. As I told last class, seventh is the one supplying middle finger, middle is the longest finger, and seventh cervical spine is longest spine. Easy to remember. On the before 2 is 6 and after 2 is 8. So simple and straightforward. Okay. So
Okay,
you
sir.
know L1, 2, 3, 4, 5. Everything's crystal clear now. You know all clinical methods. Now tell me about the cutaneous nerve localization. Each nerve has got separate localization. So let us go to that. This is the pattern of sensory loss in a patient. What is the diagnosis? Sensory loss here.
Radial nerve.
Very good. Super. Next one. What do you think about this?
Median nerve.
Good. What is happening now?
Ulnar.
Ulnar nerve. I have got sensory loss over the medial aspect of my forearm. What do you think is the problem? Medial aspect of my forearm. Which nerve is involved?
Ulnar.
That is wrong. Medial cutaneous nerve of forearm.
Yes,
Ulnar
sir.
nerve supplies only till the creases of the wrist joint. After that, the medial cutaneous nerve of the forearm and medial side of the arm is supplied by
The
medial
medial
cutaneous
cutaneous nerve
nerve
was the
arm.
arm.
So you must know about each nerve. So basically, when you have got sensory complaint, you organize yourself and find out first proper examination, and you have got area of sensory problem. Then you think it's a root, nerve, plexus, whatever it is, and then that's how you localize. So basic thing is you must know both nerve distribution and so here is all upper limb nerves. See the ulnar nerve, it stops at wrist, then it's something else. So very essential to know this distribution. And come to the all lower limb nerves. This is how it goes.
Yes, sir.
Got it?
Yes, sir.
So that you must have an idea. Sciatic nerve, lateral popliteal nerve, okay? Obturator nerve, where is it gone? So this is very essential to know. Saphenous nerve, femoral nerve, you must have pattern distribution in your mind. Sensory disturbances in various spinal cord lesions. So you find pattern like this. Complete transversal thoracic cord, as you already said, all modality sensations are lost. Now, what is this? Weakness one side, sensory loss opposite side, a band of hyperesthesia, Brown-Sequard syndrome. Okay, no problem. And this is cape-like distribution, you said. Why you get cape-like distribution? Because your fibers are crossing just close to the central canal. Syringomyelia, for example, or central lesions always involves the fibers that are very close to it, and it is the turn of the pain and temperature fibers to get involved first. So only the crossing fibers will be involved. Obviously, tracts are not affected as such. So that particular fibers which are crossing will get into trouble. Look at these patients. Upper limb fibers are crossing, only that is affected. The sensations above that level and below that level is not involved. Because site of involvement is not the tract, but area around the central canal. Only the crossing fibers will be caught. The fibers crossing above that level, below that level will not be caught. So it will be a few segments only. That's why it's called as suspended anesthesia. Okay.
Yes, sir.
Now what is this pattern? What white area is spared. All other areas, everything is lost. That is spared area. Sadly, it is spared here. All other areas are
Sacral
affected.
sparing.
Sacral sparing, which condition? So what happens is, as this lateral spinothalamic tract enters the spinal cord, they cross to the opposite side, and the column, you can imagine column into different laminations. It goes to the ventral lateral area. That area of that column will be occupied by sacral fibers. Just medial to that will be lumbar. Just medial to that will be thoracic. Then medial to that will come cervical. So C, T, L, S, that pattern from center to periphery. So when you have a lesion affecting the central part, okay,
Yes,
minimum pressure is seen over the sacral area, and that area may be spared to start with. Okay, so advanced interaction lesion can have sacral sparing. And what is happening here? Okay, so what are the findings in anterior spinal artery occlusion? Anterior spinal artery occlusion. See, there is a 3 columns given lower below, and you can see the column shows that some striations. That means this area is all lost for pain sensation and temperature. But touch and the posterior column is spared. What do you think? The touch is spared, posterior column sensation is spared, pain and temperature is affected. So basically this is what happens.
Pain and temperature present. So
anterior spinal artery occlusion.
Anterior and spinal artery.
The posterior part of the cord is spared. So proper examination is important in the sense, first to delineate the anatomical area, then inside the area, as I already told you, the different sensation has to be tested separately. Then only you will get this type of dissociation. So one example of dissociation is anterior spinal artery occlusion. Another example is syringomyelia. There will be B12 deficiency, where you find some tracts are affected, some tracts are spared. Okay?
Yes, sir.
What is happening here? This patient is going on a horse. That particular area, saddle area, is having anesthesia. What do you think? Horse rider, it's a saddle anesthesia. He doesn't know. When he goes to toilet, he washes that area. He does not have the feeling. So this is called
Saddle anesthesia, back anesthesia,
cardiac lesion. So now we have learned so far, by just properly examining and delineating the area, you can make a reasonable anatomical localization, and also by testing different sensations, how to differentiate and make a proper diagnosis. So sensor disturbance, what is this? Crossed hemianesthesia. So brainstem lesion. Okay, crossed hemianesthesia. This is hemisensory loss.
Hemisensory loss.
Okay, so today's class, basically we are just going to tell you clinical methods only, how to test. So tell me how to test for touch sensation. Yes?
Touch sensation with cotton.
What are the precautions you take? When you test the sensation, the hair should not move. That is basic thing. Hair should not move. And you should not apply pressure. You must start from the anesthetic area to normal area. And how are you going to test for pain? What do you want to test for pain? Knee hammer or tuning fork? What do you want?
Sharp pin.
Pin is never used. Pin is never used. Toothpick. How do you hold it?
With
between your fingers.
Between index finger and middle finger.
Middle finger. You should not hold like a ordinary pen. You must hold it so that you get equal pressure. And when you test for vibration, what is the strength of your tuning fork?
Um, height 128.
128. And when you check for the joint positions, what is the precaution you take? You hold at the
Hold
sides
the joint.
only.
Hold the joint.
At the sides. Sides. Okay. So
Yes.
some questions to JR. Tell me who is the JR speaking?
Sir, Vishnupriya.
Pardon?
Vishnupriya, sir.
Vishnupriya. Okay.
Yes, sir.
So Vishnupriya, tell me about structure of thalamus.
Thalamus is, there are two thalami, bilateral thalami, and each thalami is divided into three: anterior, medial, and lateral by internal medullary lamina.
Very good. Okay. What's the blood supply?
Posterior communicating artery.
And
branches from posterior communicating artery, posterior cerebral artery.
what are thalamic sensations you know of?
Sir, all sensations are relayed in thalamus.
No, thalamic sensations are abnormal sensations when thalamus is affected, which includes hyperesthesia, hyperpathia, allodynia. Okay. Tell me something about thalamic syndromes. Okay. What are the cortical sensations you know of? You already mentioned that. So, structural thalamus you already said. Can you identify the areas you already suggested?
Yes, sir.
Tell me.
Anterior nuclei.
Yes.
Laterally, there is ventral and posterior, ventral and dorsal, and dorsal portions. And in ventral, there are mainly two nuclei: anterior, posterior, and intermediate.
Okay.
And posteriorly, it is pulvinar.
Posterior it is the pulvinar. Okay, pulvinar of the thalamus. So you know the structure and blood supply mainly from the vertebrobasilar system. Okay.
Okay.
So do you know any syndromes in relation to thalamus?
Sorry.
Okay, you will come to that. So there are different types of lesions seen in thalamus. It may be paramedian territory, thalamo-geniculate territory, tuberothalamic territory. Okay, so territory of the posterior caudal arteries, and there is something called pseudothalamic syndrome as well. Over to Kartika. Tell me about thalamic syndromes.
Yes, sir. The classical syndrome is Dejerin-Rossi syndrome, which is due to occlusion of thalamo-geniculate artery.
Thalamo-geniculate artery. Yes. Thalamo-geniculate artery produces what problem?
It produces hemianesthesia, hemiataxia, mild hemiparesis. Thalamic pain occurs, and some choriothetoid movements, which is called the thalamic hand. All these are features of Dejerin-Rossi syndrome.
Dejerin-Rossi syndrome. That's your syndrome. Okay, fine.